be a lot of fun. So, and with that, I'm going to go ahead and hand it over to Dr. Cynthia Wang, who is a pediatric otolaryngologist at University of Texas Southwestern, or at Children's Medical Center, I guess. Cynthia, please.
Awesome. Thank you, everyone, for joining us this evening. For the sake of time, I just want to be respectful. We'll get started soon. I just wanted to quickly introduce our guest speakers today. I'm very excited that they have taken the time out to join us and teach us about this hot topic of a tongue tie or ankylosing. We have three guest speakers today, the first of which will be Kandi Trevino. She is one of our awesome speech language pathologists with whom I have worked in many clinics now, be it with kids with trachs or pediatric airway. And she also works with Dr. Lenes-Voit in a tongue tie clinic. So she's going to be sharing some of her expertise with us today. Next, we'll have Dr. Lenes-Voit join us to talk about the kind of treatment options for pediatric tongue tie. She started actually our tongue tie clinic here at Dallas Children's, which has been very, very well received amongst our parents and patients, I should say, although they're usually too young to kind of voice that. But and I've also had the pleasure of training with Dr. Lenes-Voit as a resident together at UT Southwestern. And then lastly, we'll be joined by Dr. Anna Messner, who joins us from Baylor College of Medicine. She is the current division chief of pediatric otolaryngology there, and she is a leader in this field of pediatric otolaryngology and has published quite a bit on all various topics, including ankylosing. She's also served as a former president of the American Society of Pediatric Otolaryngology. So very excited to have her join us today. So without further ado, I'm going to let Kandi go ahead and share her screen and we'll get started. As just a quick reminder, we'll take questions at the end. So if you want to type in those questions in the chat box, we can address them. We'll have about 5 minutes at the end to answer some questions. Take it away.
All right. Okay. Does it look good on your end, everyone on my team?
Looks great.
Okay, perfect. And thank you for introducing us. I'm Kandi, speech language pathologist at Children's Medical Center. These are our disclosures. And just briefly, some information about our tongue tie clinic at Children's. We try to reserve all of the spots in this clinic that's held twice a month. We try to hold all of these spots for infants who are having feeding difficulties, but occasionally we will see older patients if there are some speech concerns. Most of our referrals come from PCPs, SLPs, lactation specialists, but parents can also self-refer just by calling the ENT clinic and making an appointment. If we do recommend a frenotomy, those procedures can be done by Dr. Lenes-Voit in the clinic. For our younger infants, there's a little bit of wiggle room with the babies between 3 and 4 months. Kind of just depends on how strong they are and how active they are. But for our older infants, they will need to go to the OR for general anesthesia. And as far as assessments go, we do approach all of our evaluations collaboratively. We work hard to provide a supportive environment for our families. Parents are usually exhausted and maybe overwhelmed with having a new infant on top of the feeding difficulties that brought them to our clinic. So this piece can be super important. And when needed, we will counsel mothers on the physiology of lactation if the parent is wanting to include chest feeding in their infant's feeding routines. Some others just need a little bit more guidance and education to make this work, because we know that as some of us may know, breastfeeding can be very difficult. For initial workup, there are several areas that we want to work through. We look at growth trends and we talk to parents about feeding routines. And this just helps us get a better understanding of the impact of the feeding difficulties. Of course, when growth is not going well, it's obvious that there's a problem somewhere, but sometimes growth trends can actually look really good, but we're seeing concerns in our evaluation, or the parent is reporting significant issues. And if that's the case, the next step would be for us to figure out how and if the infant or the feeders might be compensating. And we can usually figure this out as we're moving through the information about the feeding routines. An example of compensating might be an infant that has oral motor difficulties, possibly from a tongue tie, but maybe mom has a rapid, heavy letdown or just an oversupply if they're breastfeeding. And so the infant's just not having to work very hard in order to maintain those nutritional needs. Or if the family is bottle feeding, maybe they figured out that a nipple with a faster flow rate helps to get those volumes down, even though that can sometimes compromise the quality of the feeding and cause some distress. So knowing if there are compensatory strategies going on is important, because as those nutritional demands increase for the infant, those strategies just may not be effective anymore. And as we're moving through how those feeding routines look for the family, we can also identify other things that may be causing issues and address those as well. I'm going to pass it over to Dr. Lenes-Voit. She's going to talk about the rest of the initial workup.
So I find that it's really useful if we have the delivery note for really young infants, because there's just a treasure trove of information that may inform sort of the way that I'm thinking through things and the way that Kandi and I are approaching the issue. And that's because, particularly if the family is trying to breastfeed and we're supporting that, there are, multiple factors that can affect maternal supply, and that can really affect the breastfeeding relationship and journey. And so I'll try to see, was the baby born at term? Are they having trouble feeding just because they're really small? Did mom potentially have a difficult pregnancy or delivery with risk factors for poor maternal supply, having a prolonged induction, having an urgent C-section, having hemorrhage, having potential retained placenta, having hypothyroidism, having PCOS? All of those things can be risk factors for poor maternal supply. And often that information is contained in the delivery note. And so that gives us a nice prep before we're even meeting the family to try and figure out, okay, where are we going to need to be meeting them? Is it going to, likely just be an oral mechanical issue, or is there something else going on? And if that information isn't available to us, we do try to assess that and solicit that information from the family. Obviously, if the patient is breastfeeding, we want to try and figure out how it's going. It's very different when, a P4 mother who successfully breastfed her older 3 infants tells me the latch doesn't feel right, no matter how I position the baby. We can't get a deep latch, versus if it's a first-time mom who is just kind of trying to figure out, because this really is a diet. It's up to both parties in the dyad for it to be successful. Of course, comorbidities, we're PD ENTs, we're always looking out for airway issues, if there's noisy breathing, if the jaw looks recessed, if there's concern, even for torticollis, and different factors that all can affect these things. We can move on to the next slide.
Okay, so for the oral neck exam, at least from a speech perspective, I can get a lot of information about how the tongue, the lips, and the jaw are moving just by observing the infant at rest, or when they're engaging in some oral exploration or making sounds. When I'm looking at the tissue, I just want to know where it's attached. Is it more posterior, anterior? Is it long and thin? Which may be allowing for more movement, or is it short, possibly anchoring the tongue down? And then how does that tissue feel? And is it easy to sweep our finger under the tongue or get it across, or even to palpate? Is it hard to get to, hard to get under the tongue? Is the tissue soft, or is it bulky and tight? And can we manually elevate the tongue? And most importantly, how is the tongue or the lip functioning? So always want to prioritize function over appearance. Regarding that lip tissue, we're aware of the dental implications of that thick frenulum tissue that wraps around the alveolar ridge. But in my experience, it is rare that a labial frenulum will keep that upper lip from flanging or being soft and flexible. Parents often report that they are worried about lip tissue because it rolls under during feedings. So we just talk about the fact that it's normal for an infant's lip to roll under. Every infant's lip will roll under at some point during a feeding, especially when they're breastfeeding, just because there's more tissue there to push up against. And it's okay to take your finger and flip the lip up. And for the lingual function, we just want to look for all those major movements, as well as trying to get an idea of the quality of the suck. I know it's not always easy to elicit a suck with a gloved finger, but I think it's important to try because it can give us some really good information, additional information, if the infant decides to cooperate, of course. And what we want to feel when we're eliciting that suck is a really good, strong pull, pressure, and wave all throughout the whole tongue. If there are restrictive tissues, what we might feel is just more of a compressive pattern, which would make it feel more like the infant is chomping. Everything's just kind of more interior. Or we might just feel a small wave or a partial wave in the tongue. I just recommend that you be cautious when interpreting that information because the sucking patterns for are different for nutritive versus non-nutritive sucking. What's going to happen is the infant's going to latch on reflexively, hoping for a feeding. And then once they realize that they're not going to get any milk out, then those patterns are going to change. So don't put all of your weight on it, but I think it's important to try because it can be a helpful piece of information. This is a great example of how the lip frenulum tissue changes over time, how it recedes. That first picture, you can see that thick frenulum tissue wrapping around the alveolar ridge. And then 5 months later, after those teeth have come in, the tissue looks very posterior. It looks really good. But most importantly, you can see just how flexible that upper lip is in both of those pictures.
Thanks, Danny. You too, bud.
Okay, and there are structural considerations that may cause issues, but not necessarily dysfunction that we want to consider, such as a high arched palate that can sometimes cause really noisy feedings. So it might sound slosh, you might hear a clicking sound just because of that interference with being able to create adequate oral pressure when there's like a vaulted or a higher palate. And clicking is a very, very common report that we hear from parents in our clinic. And I feel like parents have learned somewhere that clicking equals tongue tie, but that's not necessarily always the case. I want to look at the size and the position of the tongue. Some babies have a tendency to kind of have their tongue more protruded, pushed forward, others more retracted, and some of them have larger tongues and smaller tongues. So those kind of issues, if they're kind of atypical, can cause difficulty keeping a good latch. You might see some anterior spillage, but it may not be bad enough to be causing any problems. And we also know that we need to be careful with retracted jaws or micrognathia, because if we do release tissue, then that tongue base can fall further back into the airway and cause more problems. And then, of course, just overall tone can cause just any of these problems. And some babies just don't have as vigorous as a suck. They might have a weaker suck or a weaker latch. You might just see spillage, but there's nothing else going on. They're just, I guess, a softer baby, but they're still able to meet their nutritional demands. So not always causing dysfunction, but maybe just a little softer. I think it's just important to keep in mind that oral structures and mechanics vary and are dynamic. We all use our oral structures to achieve the same thing, whether it's for feeding or speech. And this chart can help us see how issues and problems can overlap and all the things that we need to consider when there are feeding problems. As you can see, the top row there, the dark blue row is just the most common parent report concerns that we hear, and then everything underneath are possible causes. So as you can see, oral motor difficulties can be the culprit for many, if not all feeding difficulties. And then going all the way down to cluster feeding, I think it's just important to kind of talk with families about what's going on with feeding routines and identify if this might be going on, because it can feel and look like a huge problem for parents, especially for the mom who's breastfeeding, because it just feels like you can't keep up. Moms start to think that maybe something's up with their supply or they're not doing something right. So I think just sometimes a discussion about that can go a long way. So with or without tongue tie, there are some simple changes that can be implemented that can sometimes drastically improve the quality of feedings. And this is my favorite part of my job, and I can go on and on about it, but just for sake of time, I'm just going to mention a couple of ones that I think are super important. So for positioning, we just want to always make sure that 100% of the infant's weight is supported by the caregiver. So everything is midline, extremities are flexed inward. This is just going to help the infant get a better suck, swallow, breathe rhythm, and just be able to help overall coordination, because all they're having to do is focus on oral part in feeding. And with flow rate, there are some changes that we can make that make a huge difference as well. There's a fine line sometimes with just being able to achieve quality and efficiency in a feeding. So too fast of a flow rate would look like a baby would be gulping, you know, some spillage, coughing, choking, trying to keep up. And then maybe a flow rate that's too slow is going to have the infant working too hard. Infants might be having really long feeding times if that nipple flow rate is too slow, and then they're just burning more calories than they're taking in. So both of those things, overflow or underflow, can definitely cause problems such as aversion or just problems with weight gain. And then, of course, just knowing when to refer out is important. I think I might sleep. Okay, sorry about that. So just because 99% of parents will ask about how speech and tongue tie relate, I just wanted to mention these studies here. And basically, they've concluded that we just need better uniform studies, better quality studies, clinical studies on this topic related before we can make any determination. And I think Dr. Anna Messner is going to have some more data about that. So for older children with tissue in question, and if I am asked to do an evaluation, most of them are already receiving speech therapy for an articulation disorder, and parents have been guided to our clinic just for further evaluation. So I will get a speech sample and I'll look at oral mechanics during imitation of oral motor tasks and watch for placement of specific sounds that would be difficult if there are restrictive tissues. But I can say from the evidence from my own many years of treating speech and language disorders that most kids on my caseload with articulation disorders did not have tongue ties, and maybe just a handful and 20+ years that had a history of tongue tie. But the studies have told us that tongue tie release can help with breastfeeding. If there are oral motor difficulties for an infant, we're probably first going to see that with breastfeeding. And so the studies so far have shown us that releasing restrictive tissues will help with breastfeeding. And then I'm going to pass it over to Dr. Lenes-Voit for the rest.
Awesome. So I'm going to present just a series of optional tools that are standardized tools that can be used to kind of describe tongue ties. And some of them are incorporate functional components, and some are more descriptive. And one of the big things that Kandi and I always try to teach our residents is that function matters more than what it looks like, and make sure that we're not being, that we're not missing something else, that we're not missing a potential zebra just because there's a tongue tie staring us in the face. So those are kind of our governing precepts, and we're trying to make sure we're having a comprehensive approach. So one is called the Bristol Tongue Assessment Tool, the TABI Assessment Tool, and then there's a functional tool called the Hazelbacker, as well as the Corliss, which is just descriptive. We can go on. So this is kind of the Bristol tongue assessment tool. You can see that it includes some extension measures as well as physical mechanical measures. Go on. And then this is the tabby tool. So it largely looks at where the tissue fixes on the tip of the tongue, but also at the alveolus. And that's important to be assessing both of those because it can affect function differently. And then looking at elevation and protrusion as well. Keep going. We utilize several portions of the Hazelbacher tool in our clinic looking at function. Young babies will have a reflex to lateralize if you rub along their lower gum. So if you're just rubbing along the inferior alveolus and you rub side to side, their tongue should follow you, and you can assess, is the whole tongue following? Is it just the body of the tongue? How mobile does it look in that orientation? When you insert the gloved finger to assess for the set quality overall, you can assess whether or not the tongue is able to cup, whether or not it's able to elevate. Often babies will be sticking their tongues out at us in clinic, which helps us to get an idea of what the mobility is. And then snap back on this, I've always found a little bit challenging, but the peristalsis, I think, is a really, really helpful measure, particularly for the controversial posterior tongue ties. And what Kandi and I have noticed over time is that, first of all, everyone's got some form of frenulum tissue. It's just a question of, can we only feel it or can we see it? But in these maybe functionally significant posterior ties, which are not all of them, what we've noticed, in addition to sort of red flags on the history, is that when we do the gloved finger exam, that often at the very anterior portion of the tongue, there may begin to be some peristalsis, but it halts about a third or halfway back in the tongue, and it's not coordinated across the whole body of the oral tongue. And I've also noticed that after frenotomy in those cases, that lingual wave corrects itself. And so we use sweeties to do our procedures. And so, that kind of induces the babies to be more motivated to give us a suck, particularly when holding pressure after the frenotomy. And that it is often remarkable how you'll go from a very compressive, chompy pattern where the baby seems to be trying to compensate for the fact that their tongue isn't as mobile. And you will feel the peristalsis just at the anterior tongue. And then after the release, you can feel it going all the way back. You can keep going. The appearance is just kind of the typical things we look for, the length of the frenulum, the items that Kandi talked about earlier. And then again, the attachment both to the tongue and to the gingiva floor of mouth. We can keep going. The Corlos classification, I use this just descriptively so that I know sort of where the insertion was. And then we have some photos coming on to give examples of that, which we'll go through. So these are courtesy of the International Association of Breastfeeding Leadership. So these are some Corlos type 1, the classic heart-shaped tongue. You can see that elevation is very impaired. And keep going. Corlos 2, a little bit further back. Corlos 3, even still further back. Sometimes only visible when you manually elevate the tongue. And then
Sorry, Felicity, I'm not doing that. I don't know
No,
why.
you're doing great. I love it. We're doing awesome. We got to get through this part quickly so we can get to the cases because they're the meat. So we can keep going.
Okay.
So these are some photos of one of our patients who had a pretty anterior tongue tie, and you can see just was not really able to elevate. And in that first one over to the left, they're actually trying to lateralize. And you can see they're really not able to move their tongue left to right. They're not really able to elevate. And as Dr. Messner is going to reference, there's pretty good evidence that when there's an anterior tongue tie that it can affect function, and that releasing anterior tongue ties can be helpful. And we've certainly found that to be true in our practice, particularly in situations where the dyad, really is motivated to breastfeed. I think that over time, my bias has become to be, to do more procedures than in the beginning, in order to try and support that breastfeeding, particularly if mom has pain. Because the Cochrane review that looked at frenotomy for ankylosing found the only item of significance it found was that there was decrease in maternal pain when they did their meta-analysis. And as someone who breastfed her kids and it was very hard, I think that's a good enough reason. Let's make it a little bit easier for mom. But I still want there to be some evidence of functional issue before we're going to do that. And I do think that most of the time in these Corliss 1 ties, there is a functional issue. It's rare that we find someone with a Corliss 1 tie who has no restriction of their movement at all. It does happen, but it's less common. We can keep going. And then, so it doesn't show up great in the picture, but Kandi and I have found some weird stuff. So this patient actually had an anterior tie and then a hole and then another posterior frenulum in between them. And we were trying to get a picture with a moving squirmy kid, but it's just a reminder to say that you can see just every variation under the sun.
Mm-hmm.
And this is just an example of a kid who really couldn't elevate unless we helped him out with the groove director. So this is a Corliss 3 frenulum. It's not the traditional type of frenulum that you would see, but it really impacted this child's elevation and their lingual wave as well. And so we ended up doing a frenotomy procedure for this kid, and that was an example of a time when we had a lingual wave after the procedure where we really did not have one. We had that chomping compressive pattern before we did a procedure. We can keep going. Those are just Corliss type 4. Sometimes I feel like with the Corliss type 4s that I only see them when we elevate with the groove director and I really palpate them before that point. And so as we move forward sort of to my last slide before we go on to Dr. Messner talking about all the evidence behind tongue tie, I want to just kind of dive into the controversy of posterior tongue tie just a little bit. I think of posterior tongue ties as this Corliss 3 and 4 tissue, and note that in most people, this is actually a normal frenulum. I have a Corliss 3 frenulum. All of my children have Corliss 3 frenulums. It's a normal structure in many humans. And this is where the functional exam, I think, is really important. And also staying cognizant of our goals in terms of, the parents' goals for how they want to feed their child, and striking that balance between having, a mutually productive and respectful relationship with the patient and the family, and also making sure that we're not allowing harm to come to the child, particularly at our hands. So, particularly for posterior frenulums, I really need to see some issue in terms of either growth with function, and then also just motivation to breastfeed if that's the issue. I think it's very hard to make an argument that a Corliss 3 or 4 frenulum is going to affect speech in the future. And so we get a lot of people coming to see us who want that tissue cut as a potential prophylaxis for speech issues. I don't think that's clinically appropriate, and we will educate them about that and talk them through that. But I also think that it's important to check, because sometimes these pieces of tissue do impact the feeding experience, and don't want us to be rejecting them out of hand. The more posterior ties do tend to bleed a little bit more with frenotomy. So I've also gotten a little bit more wiggle room over time in terms of how old I will cut in clinic. I know Dr. Messner is more, has been doing this a little longer than I have. And so her skill level and her confidence levels are higher than mine. So she'll do it in older infants. For me, if they will still have a reflexive suck and they're older than 3 months, then I will do it as long as they're hungry and I'm confident that they will take a bottle after the procedure. And as long as they got their vitamin K, if they're exclusively breastfed, or they've had vitamin K containing oral formula for at least 4 to 6 weeks, which is what the hematologists tell me will work. I had a patient very early on after I finished my fellowship who bled for over 45 minutes in clinic. And, as much as we should be governed by evidence and not by anecdotes, that really stuck with me. And so I'm little by little inching my way back to being more adventurous about that. But if kids have not had their vitamin K and they come in 5 days old, I'm not going to make a hole in their mouth. So that's sort of the conclusion of my portion of the talk. We'll talk some more as we go through the cases, but Dr. Messner's got some wonderful summary of the evidence around the controversy for us now.
Okay, everyone. Can you hear me? Okay, great. So thank you. I actually think our thoughts align on many of this stuff, which is nice. I was assigned the part to just talk a little bit about the literature and what's in the evidence. So let me just go through a few key points. There's obviously no way I can cover it all, but we're going to at least cover a few key things. If this would advance. All right, so we're going to do it in a question format. We have 5 questions. So the first question is, does anterior ankylosing affect breastfeeding? And the thought is, as you've already thought, that if you have anterior ankylosing, and this is a picture of what we call a type 1 anterior tongue tie, that it'll cause difficulty latching on, prolonged sore nipples, and then it can potentially affect the weight gain, milk supply, and early weaning. So the good news is there are 5 randomized controlled trials. And I put an example of one of them, 57 babies, 48 hours of support versus frenotomy plus for support, and 96% of the frenotomy group improved versus 3% of the controls. Bottom line is all of them showed at least some positive effect for breastfeeding. This is another kind of classic study. I love this study. It was 24 mother-infant pairs who had breastfeeding difficulty. And what they did is while the baby was breastfeeding, they actually put an ultrasound probe under the baby's chin. And they did it before and 7 days after frenotomy. And basically they found that all these different measures listed improved, and the ultrasound showed less compression of the nipple by the tongue post-frenotomy, exactly what we were talking about with the chomping going away. This is one of the more honest studies that's out there, which I think is super important. So it was prospective, and what they did was they did a breastfeeding questionnaire before, 1 week after, and 3 months after the initial encounter. They actually had a great sample size, 314 babies who underwent a frenotomy. Notice that the vast majority, almost all of them, had type 1 or type 2 ankylosing. There were a few that had posterior, but most of them were anterior. And this is what they found. So the red is 1 week after the frenotomy, and the blue is 3 months after the frenotomy. Can you see my pointer there or no? Yeah. Okay, so almost 20% of them actually quit breastfeeding after the frenotomy. 1 week, 5% were actually worse, okay, compared to 3 months, 1%. About 20% showed no improvement. At 1 week, about 35% had mild improvement, 17% had, at 3 months had mild improvement, and then 3 months later, so 1 week, 20% had moderate improvement or marked improvement, and 40% had moderate or marked. So the conclusion on this study is that yes, it can really affect breastfeeding in a positive way, but it's not a cure-all. And unfortunately, some of these families come in after going online to all the websites where they think, breastfeeding is so hard, all I need to do is clip the tongue, and then everything's going to be glorious and wonderful. And if it doesn't happen, then they think, oh, there must have been something wrong with my tongue tie clipping, or, clearly I need to have it clipped again, and all these other things without looking for other causes of their breastfeeding problems. So the answer to question 1 is, does anterior ankylosing affect breastfeeding? The answer is often, but not always. But there's good evidence to show that it really does help to do these frenotomies. Question 2, and Felicity got into this a little bit, but does posterior ankylosing affect breastfeeding? So the bad news is the literature on this is a mess, in my opinion. There are some studies where they boldly claim in their abstract and their conclusions that yes, it does. But the studies are really fraught with a lot of problems with their methodology. And we don't have time to go and pick through all of them, but there are some. And this is just a reminder of types of tongue tie, the anterior versus the posterior. This would be more of a type 3 and the type 4. And notice how on this, to me, this is not tongue tie, frankly. This one probably is. And I personally, over the years, we all talk about how we evolve, have learned, I now pay more attention to where the frenulum inserts on the alveolus compared to where it inserts on the tongue. And I think that's hugely important. So I kind of joke that some people think that the definition of posterior tongue tie is anyone who does not have anterior tongue tie, because everyone has a frenulum. And Felicity, I mean, they made the same point, which is, unfortunately, and I'm going to pick on the dentist here, there's some pediatric dentists out there who are declared that they are tongue tie experts, but they have never met a mouth that did not have tongue tie, in my opinion. We see it over and over again. They're recommending all these procedures, and frankly, they're recommending procedures on kids with normal frenulums that are not affecting them. So the answer here is, does posterior ankylosing affect breastfeeding? And the answer is actually not clear. Depends on your definition of posterior tongue tie. Likely, yes, in some cases. And I have evolved to thinking that initially at one point I was like, nah, no way. But I do think that sometimes it makes a difference, especially when that tongue is tethered to the alveolus. But it's likely a minority of infants. And most of these posterior tongue ties are really just normal frenulums. Question 3, does ankylosing affect speech? Kandi got into this a little bit. So I'm going to show you 2 studies. Hang with me, but these are actually probably the 2 best studies. Maybe Kandi knows something else that are out there. So this one, both of these studies are prospective. This one was 25 kids who were referred with tongue tie and they had a speech concern. They were seen by the speech language pathologist. They were administered this test, speech test I know nothing about, but I'm sure Kandi does, pre-op and 1 month post-op. And they also did audio recordings, pre and post-op, that could then be rated by people who had never seen the kid or the tongue. They found no statistical significant difference in the speech testing. They found that the vast majority of the speech sound errors were actually developmentally appropriate. And this is true. Sometimes we get these 3-year-olds and the families are like, oh, well, he doesn't make his sounds right. And you're like, well, he's 3, right? And so these kids, it's pretty normal. And there was no consistent speech sound error pattern. So there was no consistent pattern that they could associate with tongue tie. But interestingly, after the tongue tie release, almost half the parents reported that they noticed an improvement in their child's speech, despite no objective improvement. So that is an interesting finding. It speaks a lot to the placebo effect, but it may speak to that there's also some subtle things going on that we are just not quite testing for yet. This is the second study I wanted to show you on speech, also prospective. They had 3 groups, one with no tongue tie, one with untreated tongue tie, and one with treated tongue tie. They had 59 kids aged 2 to 5. They did tons of speech eligibility ratings, and they measured their oral motor skills. They found no difference between the 3 groups with speech or intelligibility or tongue mobility. So the question, does ankylosing affect speech? The answer is ankylosing does not typically affect speech. I think most of us think there's probably the occasional kid out there who may improve with their speech. But there are a lot of kids with tongue tie who speak just fine. And I think it is fairly rare. And I realize this goes against what many, many people think, but the data, the literature does not support it. Now, this term, like ankylglossia, does not typically affect speech. I use that all the time in clinic. I confess I stole it from the clinical consensus statement that was put out by the AAO back in 2020. So it's beginning to get a little dated, but it's pretty accurate as to what's out there. And I just want to remind the group that the tongue tie is never the cause of failure to talk. Regularly, I don't know about you guys, but I see parents come in, my child's not speaking, and they have tongue tie, and we want you to clip that tongue because we want our kid to talk. And frankly, usually it's autism, at least in my clinic, unfortunately. And autism is rampant. And I feel for these families, but after you spend a little time with them, you're like, oh no, this is not tongue tie. So that's where we say, you know what, we really need you to get your hearing tested and make sure your hearing is okay and see a speech pathologist, because it really is likely not the tongue tie. Question 4 is, what is the best way to perform a frenotomy in clinic? There was a systematic review that looked at all the papers that were out there that basically concluded there is no clear advantage for one type of frenotomy technique over another. So the answer to that question is there is no best technique, but lasers are being used as a marketing tool. And here in Texas, it is big business for some people. How I do it sounds like it's pretty much what you do. I use the sucrose bullets. We just stock them in our clinic. We give them the sugar water. You can either use your finger to lift the tongue. We use sterile scissors, or you can use the groove director, either one. And then the key there is then immediately have the patient feed immediately after. As Felicity said, I typically will do it up to the time the kid gets teeth and will bite me. But I will do it, 5 or 6 months without a problem. With the exception, if it is a really thick tongue tie, then I won't. Because again, I think the risk of bleeding. But if it's thin, it's a 5 or 6 month old, I'm happy to do it then. And then the frenuloplasty pictures you see there, that's typically if you're in the OR and it's an older, thicker frenulum. And then question 5, are post-frenotomy tongue exercises beneficial in infants? There isn't a whole lot of literature. There's this one review, big sample size, almost 600 kids, 599, and half of them were recommended to do massage, and the other half were no massage. And they found that there was absolutely no difference in the improvement of breastfeeding or recurrence after the frenotomy. Although interestingly, the ones that were recommended massage, only a minority actually did the massage. And the reason this is a big issue is because parents will come into your clinic after having gone on the internet and gone on all these social media groups, and they'll say, oh, you have to do the exercises. And if you don't, then it's going to scar and come back. There is zero evidence to support that. And the problem there, so this is just answers. The answer is no. Kids will spontaneously stick out their tongue, just like this baby. Every time they cry, they will lift their tongue. Every time they feed, they will move their tongue. So you don't need to do the exercises. But this was a post I lifted from Facebook where the parent posted, okay, the initial pain of the procedure is gone. However, how do I make those awful stretching exercises less awful? It's worse than 1,000 procedures. She screams in so much pain. And so it's important, even if the family doesn't mention it, to say you do not need to do these exercises where you rub under the tongue or you lift the tongue, because frankly, I consider this just baby torture. You can end up with oral aversion from it. It's just unnecessary. All right, on to the cases. I don't know how you want to do this, but this is a 2-week-old with difficulty latching onto the breast and maternal nipple pain. We've got a bunch of cases and we have about 15 minutes or so. Felicity or Kandi?
Yeah, so I think, we would sort of look through the history like we talked about before, but the big thing here is going to be the oral mech exam. Can the baby move the tongue? My suspicion looking at this is they probably don't move their tongue correctly. And in that case, I think we'd be pretty likely to offer a frenotomy.
Yeah, I think in our clinic, we would too. I'm a huge fan of the BTAT, the Bristol Tongue Assessment Tool, which has 4 things. It looks at whether when they stick it out, it's heart shape or notched. It looks at where it inserts on the alveolus. And here you see very clearly where it inserts on the alveolus. And then how much the baby lifts, which you can usually tell pretty quick if the baby cries. And then personally, I don't have a great trick for getting them to stick it out. Sometimes if you tickle their chin, they'll stick it out. But if you have a trick, please share now.
My trick is to have Kandi with me because she's like a baby whisperer.
Okay, well, we've got great speech pathologists in our clinic, but they're not always with me. So, all right, I think that one's pretty straightforward. Let's go on to another one. Okay, this is a 2-week-old with difficulty latching and maternal nipple pain, but the frenulum looks a bit different. It does not go to the tongue tip. What do you think on this one, guys?
I think there is still that insertion on the alveolus, and I think this is where the functional exam would make a really big difference for us, as well as to some extent the feeding efficiency. What we've noticed in some of these cases is that you know, these kinds of issues can be masked in perhaps a mother who's breastfed before and has a good supply, and you know, baby will be gaining weight, so it'll look like baby's okay. But when you do the oral mech exam, the tongue really is not moving that well. Either usually they can lateralize pretty well with the tongue tie or with a frenulum that looks like this, but sometimes there will be limitations in elevation in that lingual wave. I think it really depends a whole lot on the physical exam in this case, because I've seen a lot of babies who have a tongue that looks like this, who move it fine, who are growing fine, who are feeding well. And this is where I think maternal factors, if they're breastfeeding, if mom's having pain at 2 weeks, it's tough because mom is still going to have some engorgement postpartum. And so, you know, you've got a baby who's got a relatively small mouth. You've got a mom who's got a relatively big nipple areolar complex. And so we're in a situation where things are as non-optimized as possible for people to feed, even if the tongue is moving perfectly. You just have to check and see if the tongue is working.
Yeah, totally agree. This could go either way. It is a nice thin frenulum, so if the baby was not having feeding issues, I would not worry about it at all because it likely will stretch and become a non-issue as the baby gets older. Otherwise, totally agree. But sometimes I will say families, it's almost like you have to take it off the table in order to recognize other causes of the feeding thing. And
Yeah.
it's super important to educate the family before you do the frenotomy that hopefully this will help, but it is not a cure-all.
Yeah.
It's not going to make everything perfect immediately. And there may be some other things that need to be worked on.
And a 2-week-old is still learning how to eat. They are still transitioning from that intrauterine environment where they were tube fed and had to do no work, and they're still learning how to breathe and eat and swallow at the same time. The one thing that I don't want to miss though is, you know, if they are having extraction issues, that can lead to downregulation of mom supply if they're breastfeeding. And so I would rather sort of, if mom is really motivated to breastfeed, given that I think this is a relatively low risk frenotomy in terms of just because it's pretty thin tissue, I'm getting more to the side where I err on the side of cutting it if I'm worried that maybe a supply issue is being masked by the fact that they're in the initial postpartum period. They just had this progesterone plummet. And so they're, you know, they have a good supply from that standpoint.
Yeah, it also helps too if mom is breastfed before, because I feel like we do have moms come in and they're like, this is just different. This is not the same as my first baby.
Yeah.
So it also helps to have that as a reference.
The only other thing I would add on this one is that I don't think you can trust weight gain personally.
Yes.
Because sometimes they're able to keep up the weight, but they are feeding for 45 minutes every hour and a half. So the baby is making it, but boy, are they having to do a lot of extra effort.
Yes, and I totally agree that feeding efficiency, Kandi always asks about that. And that is a more important clue than the weight gain in the early times, I think.
Yeah, how much, how often, how long the feedings are, that is super important information.
Yep, yep. So when I have a mom that says, oh, we're doing every, few hours, but it takes, maybe 10 minutes, I'm like, okay, they're not having so
You're
much.
probably okay. Yeah.
They're probably okay. Yeah, probably okay.
Unless she's just like the biggest oversupplier in the history of the world and baby doesn't actually have to extract, they're just sipping from a milk fountain.
Yep, there you go. All right, take a look at this one. So this is another probably type 1. You can see it going to the tip and to the alveolus. What do you think on this one?
I think we had some more clinical information too.
Yes.
Actually,
Yes.
go ahead, because it didn't show up on the slide.
Yeah, we have a little, this was one of our patients. And mom had breastfed before. I think she had 2 other children anyway. She comes in and she's just like, I'm just having so many breastfeeding difficulties. But she's able to take the bottle and very efficiently, but it turns out they were having to use like a faster flow nipple for her to be able to be efficient. And really just with, I mean, do you want me to tell you the end result, or did you want somebody else to guess? Or
I think you can just, you can tell us.
Okay. Yeah. So just based on mom's just desire to exclusively breastfeed and just the oral motor difficulties that we saw, because whenever I did try to elicit a suck, it was the funniest thing, because this baby had the strongest pull and pressure, but absolutely no wave in her tongue at all whatsoever. And mom confirmed that. She's like, yeah, that's exactly what it feels like when I try to breastfeed. And when she bottle feeds, same thing. It's just very, very chompy. So we recommended sternotomy. And I think too, when Felicity went, or Dr. Lenes-Voit went to do the procedure, she said that the tissue got thicker as she got closer to the genoglossus muscle. And so I think maybe you had to go further back. And I think that would explain the difficulties that the mom was having breastfeeding that we weren't really seeing with bottle feeding when a faster flow rate was being used. So we did end up clipping hers.
Okay, moving on. 2-week-old latching difficulty and maternal nipple pain. So personally, I don't think this baby has tongue tie, assuming you can get the tongue to move. There's really no prominent frenulum. And this was really more a comment that, and I didn't put in the literature, but the good literature on the lip frenulum is that it doesn't really affect breastfeeding.
Yeah.
It really doesn't. And so I just won't do it pretty much.
I agree with that, with the tiny little caveat that I've had a few breastfeeding dyads where I have felt they had a tongue tie and there was significant maternal nipple pain. And I have them come back a month later so that I can just see how they healed, and so that I can still be sort of accumulating my own data, moving forward. Am I cutting enough tissue? All those kinds of things. And so they had initially come at about a month old. Mom was a speech therapist and had a great understanding of how the oral structure should work the first time that I believed this, basically. And we cut the tongue tie. The tongue was working great. The maternal nipple pain improved significantly, but wasn't all the way gone. And mom said, can we just try it? I really want to breastfeed. And I cut the lip tie. And then when she came back for the follow-up from that, the pain had resolved. Now, I want to be very cautious. I don't know that it was because of the lip tie. It may have just been that baby grew enough and got better at feeding. But I have had enough colleagues tell me about times when lip ties helped with maternal nipple pain that sometimes I'm willing to try it if we've already done everything else. And I think things are optimized and I'm confident that baby is being supported and positioned. So I'm not a never ever person, but I'm a very, very rare person for lip ties.
I think that's totally fair. And the literature that's out there, I mean, the best one shows that how the prominence of the lip or the position of the frenulum really shows no change, no correlation to the latch scores, which is one of the breastfeeding
Right,
algorithms.
and there's actually functional MRI studies that show the lip completely turned in while actively extracting milk in the MRI machine with no apparent issue extracting the milk. And you can literally see it spurting into the mouth out of the alveolar tissue, from the breast alveolar tissue. And there's no issue. So.
And while we're on the subject, cutting that lip tie will not prevent getting a space between the upper teeth.
Great point.
And matter of
One that we
fact,
tell people all the time.
because parents come in and they're like, oh, I don't want them to get a space between their upper teeth. Makes no difference. And in fact, the American Academy of Pediatric Dentistry in their position statement says, do not cut it.
Right.
Unless you're like a teenager undergoing orthodontia and it seems to be. Now, there may be rare reasons, like a kid has trouble, brushing their teeth or something, but there is really no reason to think that cutting that would make a difference in the way the teeth are spaced.
And the orthodontist associate position statement even says, don't do it until after the canines, the permanent canines have erupted, because it'll affect tooth spacing.
There you go.
So.
All right,
So I don't mean to interrupt, but I think
there we go. Go ahead.
Out of time. I think we were planning on going through the cases until we run out of time, so I feel like we could just go forever. But I do want to open up the floor to anyone with questions. If you want to unmute yourself, or if you want to enter it into the chat. We may have one more. We have time for maybe one more case. I don't know, Dr. Messner.
Okay, we'll do one more.
We have no other questions.
Okay, so this is a 4-month-old with difficulty latching. Mom is still trying to breastfeed, but is actually gaining weight well. And then this brings up the question, what if the mom comes in and they're bottle feeding? So I'll just tell you my concern with this baby. I was like, first of all, the baby actually could elevate pretty well. And did not seem to have much restriction. And there was actually a fairly small jaw that I thought was probably contributing to the latching. But in general, when parents say there's problem bottle feeding, I don't think it's a tongue tie. And I'd be curious as to your guys' take on it.
I think our threshold to do a frenotomy without a very overt, like Corliss 1 type tie in a bottle fed baby is very high. There are occasionally parents who will tell us that they're, even with a bottle, they're spending so long feeding. If they're spending, more than 30 minutes, 45 minutes to an hour trying to get 4 ounces into their baby with an appropriately sized nipple. That to me is a reason to think about it. If there's evidence of lingual restriction on exam, not like in this baby where, you might be creating an airway problem by removing, whatever anterior pull there is. I don't necessarily think that applies, but in a baby where they have very inefficient feeds, or, we've had a couple of babies who come to us who are basically on pigeon nipples, like are on non-suck compression nipples because, that's the only thing they could figure out to make their feeding work. And in those cases, I think that giving them more functional tongue movement may be useful.
Yeah, I agree. Just finding a whole lot of information out about those feeding routines. If parents say they've tried, 4 or 5 bottles, but they still taking 45 minutes, and it doesn't matter what nipple, what position, and everything they're doing is they're still resulting in long feeding times. That, in addition to weight gain and how the tongue is moving, I think that I would need to take all of that into consideration before recommending a release for a bottle fed baby. Yeah,
I typically go more down the dysphagia pathway. Like there is something wrong or elsewhere with the swallowing mechanism. Also, it's typically not going to be the tongue, but I know we have time problems.
All right, so we have 2 questions in the chat. I'll
Okay.
go ahead and read the first one from Dr. Chung Phillips. She asks, can you comment on pediatric dentists trying to recommend frenulectomy for sleep apnea? Where do they get
Ha!
this from?
Wait. All right, this was a second opinion I had from a 6-year-old who was recommended to have laser frenotomy and actually for obstructive sleep apnea. And this was the kid's tongue that he came in with. So there are, unfortunately, some people out there who are lasering all these tongues for sleep apnea. There are some studies out there that say, oh yes, if you laser it, it will get better. In general, they are really poor quality studies that you can pick apart. So, and I hate a case like this where they were told, oh, you just have to have your tongue lasered when they have these big whomping tonsils in the back of their throat. So I'd be curious as to you, but I think this is an area of great abuse in Texas. Frankly, it's a big problem.
I always really appreciate that the clinical consensus statement addressed this, because when parents tell me this, I can point to this statement from our professional body and say that there's no evidence that our national organization has recommended against tongue tie procedures for this purpose. And then I take a good history for sleep apnea and look in their throat and look in their back of their nose if I need to. But it's really frustrating. It's because they believe, you know, you have extra work to do to get back just to the baseline.
Yep. You're muted, Cynthia.
Sorry. Okay. I knew that would happen at least once. Second question is, what's your counsel when a family comes in with a recommendation for a buccal tie release from a pediatric dentist? Sounds like there's a particular dentist that works with a speech pathologist and a lactation consultant who support these recommendations.
Yes. So mine is I really try and contain my anger for these because in my opinion, there is no such thing as a buccal tie. These are normal mucosal folds in the mouth. And there is zero evidence in the literature that shows it makes any difference. And it gets super frustrating when you see these people who have been told, oh, they need a lingual tie, they need their tongue tie, they need buccal ties. Oh, that's 4 ties they're going to have lasered at $700 a pop or whatever. So I would say I would be a little more politically correct, but I would say it's really not necessary.
Yeah, we in Dallas, there's like this 7 tie special, upper and lower lips, tongue, and then 4 buccal. And there's a couple of people who are sort of notorious for recommending these and doing them. And we've now, been having our tongue tie clinic long enough that sometimes people come in with the complications from this. And, we can see that not only were a lot of unnecessary cuts made, but the baby's actually developed oral aversion, or they've cut into intrinsic tongue musculature. They were in the wrong plane with their laser, and there's, a big open wound. And so, at this point, I just talk to them about the risks and say there are no demonstrated benefits. And here are the risks that I have seen, and babies who have stopped eating and babies who have ended up in the ER with an NG tube. And do you want to take that risk with something that doesn't have evidence for it? Because I'm not willing to put your baby through that.
You've also seen some rannulas form, right?
Oh yeah, that's right. So probably 3 or 4 times a year, I'll see a ranula, like a pseudocyst in the floor of the mouth that is iatrogenic from post laser frenotomy, where they have, one of the ducts of Ravinius has just been annealed closed, I guess, by the heat of the laser. And it's easy enough to take care of, but it's another procedure this kid then needs.
All right, I think we have time for one more question. This one asks, can you discuss using topical versus injected lidocaine versus nothing, clamping the frenulum, and your technique changes for posterior tie?
So I didn't present the evidence on that, but actually there are recommendations against using topical, especially in babies, because, well, number one, they're at risk for cardiac issues and also methemoglobinemia. So bottom line is just you don't need to. The key, in injecting, frankly, injecting these frenulums is more traumatic than just cutting it. And then you have to get in the baby's mouth twice and get them mad twice. So we use the sucrose bullets in the clinic all the time for the babies, and it works great. It works just fine. I would not do the others. And then I do not clamp. I've never seen any reason to clamp, didn't ever think it was helpful. And my goal is to get it done as quick as possible and get the baby feeding as quick as possible. So do what you got to do, but don't linger and have the baby crying for longer. And then there was one other part of that, Cynthia. You're muted again.
If your technique changes for a posterior tie.
Oh, my technique does not change for a posterior tie unless it's super thick. And then you got to really think about how you want to do it. What do you guys do?
100% the same. Yeah, I don't use any topical or injected Lido. Sometimes parents are upset about that. And so again, it's very nice to be able to point to the clinical consensus statement and talk about, you know, the risk to the baby from that. I don't clamp. I don't think it helps either. And pretty much if I am doing a frenotomy in clinic, I'm going to do it the same way every time. I go pretty far back, no matter whether it's anterior or posterior.
Yeah, I take it back to the muscle and then
Yeah.
rub my finger underneath it to make sure it's nice and smooth and you don't have any residual tight mucosa there.
And I do think
but I
that
don't take it into the muscle.
I do think the diamond in the floor of mouth gives you a nice clue as to when you've released.
Mm-hmm. Totally agree. And it's not just the consensus statement or the literature. I mean, the FDA has recommendations against using these topical and lidocaine in infants. If it's an older kid, like a teenager with a thick frenulum that you're going to do in clinic, then fine, use whatever. You can do topical, you can inject or whatever, but not in the babies.
All right, I think that about wraps everything up. I feel like we can keep talking about this forever. So to be respectful of everyone's time, I think we'll wrap everything up. Dr. Halderman, do you have anything else to say?
No, thank you guys so much. I'm so glad that I don't see pediatric patients